Hello and welcome to this guest paper series in orthopedics, and I'm Dr. Yusuf Tyagi. Let's have a discussion on the most important kind of the questions which are likely to be framed in your examination. Look, for the last year, there are questions which are regularly coming in this December session, particularly from the topic, and we are going to cover those topics, highlighting the important kind of the questions which are likely to be framed in your examination. It's not like that the entire topic is important. There are several aspects in that particular topic which could be framed in the form of your question, particularly for this MCI examination, right? So let's just start with the first topic. As you know, like for the last 3 to 4 years, consistently they are asking one question out of tuberculosis of the musculoskeletal system. Now, tuberculosis of the musculoskeletal system, particularly the question is usually asked from the tuberculosis of the spine. Tuberculosis of the spine se related, there are two questions only. One is the types of tuberculosis of spine. As you already know that the types of tuberculosis of spine, the most common one is paradiscal, the second one is central, the third one is anterior, and the fourth one is posterior. And out of this, the paradiscal is the most common type. So this is one question. Another question is that there could be a long question asked, which is assisted with the X-rays. And what you have to identify in the X-ray is that one of the intervertebral disc is completely degenerated and the two vertebrae are angularly aligned to each other, which are about to get fused. So this is a single level spondylodiscitis that you have to identify, marking the answer as tuberculosis of the spine. So for MCI examination, be prepared that these are the two questions for you for tuberculosis of the spine related topic, right? Apart from this, they can also give you like what are the clinical features related to the neurological deficits. So this we have already talked about, like in stage 4, particularly there will be a bowel or bladder involvement, and if they are asking anything related to the stages, then they are bound to give you a stage 4 for the neurological deficits and tuberculosis of the spine. Alright. Similarly, they ask the questions about tuberculosis of the hip joint. Now, tuberculosis of the hip, there are again two questions. One is the most common site, first site to be affected. That obviously is the acetabulum, which you already are aware of it. And the second point is that what are the different stages of tuberculosis of the hip joint. Now, stages, although we have discussed this much in details, understanding the concept behind these stages, but at this stage of time, what you have to remember that there are 4 stages. The stage of synovitis, which results in flexion, abduction, external rotation of the hip joint, resulting in apparent lengthening. That means the length of the limb is not increased in true sense. It just appears to be lengthened because of the compensatory down tilting of the pelvis on the affected side. So there is apparent lengthening. On the other hand, the second stage is the stage of early arthritis, which results in flexion, adduction, internal rotation, right? So it is early arthritis stage that results in flexion, adduction, internal rotation, resulting in apparent shortening of the limb. Apparent shortening means the length of the limb is actually identical. There is no true shortening. All right. And finally, there will be a advanced arthritis stage where there will be true shortening and the attitude remains the same with increased severity. So as you can see, all the 3 stages are different from each other, combining the attitudes and the length of the limb. All right. On this basis, the questions are framed. They have asked you the question of early arthritis. They have asked you the question of the synovitis stage already. And finally, the stage of dislocation. So this is what you need to remember about tuberculosis of the hip joint. So we have talked about the 2 aspects of tuberculosis knee, tuberculosis of the hip, tuberculosis of the spine. Now, till date, they haven't asked anything related to the tuberculosis of the knee joint. But if they ask you this question for the first time, then only thing they can ask is the triple deformity. Is the triple deformity of the knee joint. Why? Because these are the clinical features of the tuberculosis of the knee joint. All right. So what are the triple deformities? That means what are the 3 clinical aspects? One is flexion, that the knee would be kept in flexion. The second one is posterior subluxation. That means the tibia, it subluxates posteriorly. And the third one is lateral rotation. That means the tibia rotates laterally. So these are the 3 components of the triple deformity of the knee. If they ask anything related to the TB knee, then this is your question. All right. So that was one segment of the question solved. That means asking about tuberculosis. The second segment is the identification of the braces, right? What are the common braces, the common splints which are used in orthopedic practice? That could be asked from you. The first one, which I have already asked, is about the developmental dysplasia of the hip joint. The name of the splint over here is Parlick harness, and this Parlick harness is indicated in developmental dysplasia of the hip joint. So how will you identify a Parlick harness? Based on the Parlick harness is identified based on the positioning of the thigh. Whenever the hip joints of the thigh are kept in abduction, they are held in abduction and immobilized, then it is known as Parlick harness. All right. And what is the indication for this? Is the developmental dysplasia of the hip joint, most commonly in case of newborn. So that is one question for identification. Another one are the braces around the trunk of the body. So braces around the trunk commonly are used in scoliosis. So the indication obviously is going to be scoliotic. But there are two braces which could be provided to you in the form of images. One is around the trunk only, no cervical immobilization. So that would be a Boston brace. And this Boston brace is also known as TLS brace. TLS, that means thoracolumbo-sacral immobilization. On the other hand, there is an immobilization of the cervical column also, and this brace would be identified as CTLS, that is Milwaukee brace. Milwaukee brace is again used in scoliotic deformity, although the indications are different. But here there is an immobilization of the cervical, thoracic, lumbar and sacral column. All of them are immobilized. So these are the braces for scoliotic deformities. Another braces which are very commonly asked, very commonly framed nowadays, is that of a CTEV, right? Congenital talipes equinovarus, CTEV. And how will you identify a CTEV brace? If there are a pair of shoes which are connected by a bar. Simple, it is for CTEV. Now the splints which are used in CTEV, one is Dennis Brown splint. Now this Dennis Brown splint, how you will identify is the two shoes connected by a bar in between. So you can see there is a bar in between. On the other hand, the another one is SFAB, that is Steenbeek foot abduction brace. This is also used in case of CTEV, but there are slight differences. Like instead of a bar, there is a rod, and the abduction of the both the feet are almost up to 90 degrees. They are more abducted, right? SFAB. So SFAB as well as Dennis Brown, both of them are used in CTEV. So this is how you can identify a splint for CTEV. Another splint or a brace is the ankle foot orthosis, which already you know that this ankle foot orthosis, also known by the name of ankle foot splint, is used in case of foot drop. The indication is foot drop, that means common peroneal nerve injury or common peroneal nerve palsy, in order to prevent the fixed plantar flexion of the ankle. On the other hand, here as you can identify or you can very clearly see that the knuckles are bent. That means the metacarpophalangeal joints are flexed and immobilized. So the name of this splint obviously would be the knuckle bender splint. And this knuckle bender splint is used in the immobilization or in the management of ulnar nerve injury, right? Ulnar nerve injury. This knuckle bender splint is used. So this is just for the purpose of identification, right? Another one which is very commonly asked splint is the cock-up splint. So many times this question has been asked, and this cock-up splint is used in the management of radial nerve injury. Why? And how you will identify this cock-up splint? When the wrist is kept in extension. So any splint which is holding the wrist in extension would be termed as cock-up splint. So these are the two frames of the question that we have talked about. One is identification of the brace. First one was tuberculosis. So hopefully you will be able to identify all the braces which are likely to be kept in your examination. Then the third segment of the question is that of a cast application. You know, in orthopedic practice, ये बहुत कॉमन होता है कि कंजर्वेटिव मैनेजमेंट इज डन बाय द एप्लीकेशन और इमोबिलाइजेशन ऑफ द लिम्ब इन द कास्ट, दैट इज प्लास्टर ऑफ पेरिस. Now these casts which are likely to be given to you in the examination, one is the patellar tendon bearing cast, you know, the PTB cast. So how will you identify this patellar tendon bearing cast? If there is a cast applied below the level of the knee, that means the knee is not immobilized, knee is kept free, but the cast is applied all the way up to the tibial condyles. That means the condylar holding cast. So this is how you will identify a PTB cast. And the indication for this patellar tendon bearing cast is actually the tibial diaphyseal fracture. It is the tibial diaphyseal fractures, right? For PTB. Now, होता क्या है कि क्वेश्चंस रिलेटेड टू द पटेलर फ्रैक्चर्स आर आस्क्ड वेरी कॉमनली और पटेलर फ्रैक्चर्स आर ट्रीटेड बाय, तो उसमें पटेलर टेंडन बियरिंग कास्ट दे यूज्ड टू गिव इन द ऑप्शंस बिकॉज द एग्जामिनर वांट्स टू कंफ्यूज यू. हो सकता है कि पटेलर फ्रैक्चर का मैनेजमेंट पटेलर टेंडन बियरिंग कास्ट से हो. नो, फॉर द पटेलर फ्रैक्चर सिलिंड्रिकल कास्ट इज यूज्ड. On the other hand, we are having another cast which is known by the name of cylindrical cast, and this cylindrical cast is identified by, means how will you identify a cylindrical cast? That it is again a below knee, lower limb cast which is enclosing the entire knee joint. Knee joint को enclose करता है from the mid level of the thigh all the way up to the level of the ankle, specifically 5 centimeters above the level of the medial malleolus. But here the knee is immobilized in extension. You know, this is the only cast where the knee is kept in extension. In all the other lower limb cast, जिसमें कि knee को आप immobilize करते हो, the knee is kept in around 15 degrees of flexion except cylindrical cast. And the cylindrical cast indication is patellar fractures. The indication for the cylindrical cast is patellar fracture. So hopefully, जो lower limb cast हैं आपके, उसमें ये दो ही cast which are likely to be framed in your examination, likely to be kept in your examination. One is cylindrical, other one is PTB. एक और कास्ट आपको दिया जा सकता है related to the lower limb, and that is going to be the hip spica splint. Now, hip spica basically is used in the management of fractures shaft of the femur, fracture shaft of femur in case of children, right? Or how will you identify this? उसमें there will be enclosure of the abdomen, there will be enclosure of the pelvis, there will be enclosure of the entire lower limb, but half of the lower limb, that means all the way above the level of the knee on the opposite side also. Like if this is the individual, if this is the trunk of the individual, then the cast is applied all the way enclosing the pelvis. Apart from the pelvis, there will be a lower limb involvement all the way up to the ankle, and half of the cast is applied on above the level of the knee joint. So this entire lower limb up right from the pelvis is enclosed inside the cast. That is hip spica cast. This is the kind of the image which we have already talked about multiple of the times in the management. As far as upper limb cast are concerned, again very commonly kept in your examination, one is that of the scaphoid cast. Both of them are below elbow cast, but one is a scaphoid cast. And how will you identify a scaphoid cast? That the thumb is kept in abduction and the wrist in dorsiflexion. So the wrist is kept in dorsiflexion, the thumb in abduction, as if you are holding a glass. So that is the reason why it is called as glass holding cast. Other cast is also known as Colles cast. And how will you identify a Colles cast? That the wrist is kept in palmar flexion, ulnar deviation, like this. And this is the reason why it is called as handshaking cast. The wrist is kept in palmar flexion, ulnar deviation, right? As well as in pronation. So this is how you will identify a Colles cast. So that means for the upper limb, there are two casts which are very importantly kept or might be kept in your examination. One is that of a scaphoid, other one is that of the Colles, right? And these are the differences in between the two. So that was the third segment of the question. The first one was tuberculosis. Second one was identification of a brace or a splint. And the third one is identification of the cast for immobilization. Now, the fourth segment of the question is related to the infections, the bone or the joint infections. Now, this is very clear, like at any point, if there is a term which is related sinus given to you in orthopedics, like sinus with a bony spicule, drainage of the abscess is provided to you, then the answer for that question obviously is the chronic osteomyelitis, right? So how will you identify a chronic osteomyelitis on the x-rays? One is the sequestrum, which is a dark segment, increased dense segment of the bone surrounded by the granulation tissue. So there are questions which are likely to be framed on sequestrum. Apart from this, there could be a question asked on involucrum, and you already know what the involucrum is, that it is a bony wall around the sequestral or the inflammatory tissue inside the, or infective tissue inside the bone, that is involucrum. All right. Then the cloacae and the sinus. So these are all the clinical features of the chronic osteomyelitis which could be kept in your examination. So chronic osteomyelitis related questions are two. One is giving you the X-ray, asking for the identification. Second is long question with the sinus history. Answer for that question is chronic osteomyelitis. Now, as far as septic arthritis, that means joint infection is concerned, there are several points which are important for you to remember. Like knee is the most common site. The most common site is the knee joint for septic arthritis. And apart from knee joint, the hip is the second most common site to be affected. That is point number one. Now, point number two about septic arthritis is that, emergency investigation in case of a child, emergency investigation in case of a child is always ultrasonography. Now, you already might be thinking of that instead that MRI is the investigation of choice. This is true. But as far as emergency investigation for this septic arthritis in the hip joint is concerned in case of a child, then ultrasonography is considered to be the better investigation, a fast investigation, right? Acute osteomyelitis. Now, these are several of the points which are important, which you already know about, but what is likely to be kept in your examination are the long clinical features related to this question, but more importantly, metaphyseal involvement. That metaphysis is the most common site to be affected by acute osteomyelitis, right? So, the third question is based on the infective conditions, and in those infective conditions, particularly what is likely to be asked in relation to the chronic osteomyelitis, right? Then the fifth segment. The fifth segment, there is going to be one question always, and that is based on the tumor identification. You need not to worry too much about it. Epiphyseal tumor, you see, epiphyseal tumor, and there is no growth plate visibility. It is GCT, the giant cell tumor, that is osteoclastoma. Epiphyseal tumor, no growth plate seen. It is giant cell tumor. Similarly, central core is increasingly dense, but outer peripheries are less dense. So, this is a feature of osteosarcoma. It is a malignant tumor. And this is actually the sunburst appearance or a rising sun appearance, right? Then again, epiphyseal tumor, but the growth plates are still visible. Then this is chondroblastoma. So, this is how you will identify it. If the tumor is there in the epiphysis, but the growth plate is visible, it is chondroblastoma. If the tumor is there in the epiphysis, but the growth plate is obliterated, it is giant cell tumor. Other than this, if there is a tumor which is projecting from the metaphysis of the long bone, all right, growing away from the joint, answer for this question is osteochondroma straight away. Means you need not to give a second thought related to this particular topic. It is osteochondroma. While if there is a radiolucent point that you see in the long bone cortex, then the answer for this question is osteoid osteoma. So, this is how you will identify a osteoid osteoma X-ray, right? Giant cell tumor pe they have asked the question. They have asked the question on osteosarcoma multiple of the time. They have asked the question on chondroblastoma. They have asked the question on osteochondroma also this year. So, they used to ask this question out of this tumor just on the basis of its identification on the X-rays, right? Then again, a Shepherd-Crook deformity where the femur is typically bent as if you are seeing a stick of the shepherd, it as well as the ground glass appearance, both of them goes in the favor of fibrous dysplasia. So, fibrous dysplasia related questions are very, very imminent, means there is no problem in identifying these kind of the X-rays. Just on the basis of its identification, you can mark the correct answer. Like similarly, related to a periosteal reaction seen in the form of a tumor along the long bone, that means diaphyseal involvement, then Ewing sarcoma is the answer for this question. So, as far as tumor identification related questions are concerned, that is segment 5th of your question. Majority of the times you will be given a benign tumor for the identification. If at all they are asking about the malignant tumor, they can give you two options. One is that of the osteosarcoma. Osteosarcoma mein you might get the X-rays which are blunt in identification. You cannot have a differential, you cannot get confused that this is not osteosarcoma. It's going to be a pinpoint answer for marking the correct answers for that particular question. And the other malignant tumor that they can give is Ewing sarcoma. And in Ewing sarcoma, there is diaphyseal involvement. The age of the child is on the younger side slightly, right? And there will be a periosteal reaction in the form of an onion peel appearance seen on the long bone diaphysis, particularly in the femur or in the tibia. So, these are the things which are obviously going to be provided to you in the X-rays, right? So ये हो गया आपका segment 5th. The first one was tuberculosis, the second one was infection, the third one was braces, the fourth one was the cast, and the fifth one was that of the tumor. Now comes the sixth one, and this is considered to be the most important one, and that is related to the nerve injury. Now this is something which you have already talked about, which we have already talked about here, or you have already learned everything related to this particular topic. Here a quick revision on how the questions could be framed. Like, as you can see, this is a claw hand, partial claw, and this partial claw is because of ulnar nerve injury. There is no doubt about that. Similarly, card test could be given, then book test could be given, from and sign could be given, claw hand could be given for the purpose of identification to mark the answer as ulnar nerve. Similarly, the pen test could be given, the ape thumb deformity could be given, the pointing index could be given, the Kilonavin sign could be given, the benediction sign could be given for you to mark the answer as median nerve injuries, right? As far as the fracture related nerve injuries are concerned, this is one table of yours. अब इसमें होता क्या है कि instead of asking that what is the name of the nerve injured in proximal humerus fracture, they can give you the X-ray जहां पे there is a proximal humerus fracture and you have to mark the answer as axillary nerve injury. They can give you an X-ray जहां पे shoulder dislocation हुआ है and you have to mark the answer as axillary nerve injury. They can give you the X-ray of a supracondylar fracture of the humerus and you have to mark the answer as anterior interosseous nerve injury. They can give you an X-ray of the proximal fibula fracture where you have to mark the answer as common peroneal nerve injury. All right. So this is how the questions are getting framed today. Instead of a written one-liner, they are giving you the X-ray, they are giving you, they are providing you the clinical profile or the picture, and then they are seeking for the answer from you, right? So quick revision, although this is something that you should be able to know, like shoulder dislocation, fracture proximal humerus, axillary nerve without any doubt, fracture shaft of the humerus, radial nerve, then supracondylar fracture, anterior interosseous nerve, elbow dislocation, ulnar is the most common nerve to be affected, Monteggia fracture dislocation, posterior interosseous nerve, which is a motor branch of the radial nerve, Volkmann ischemic, again anterior interosseous nerve, the posterior dislocation of the hip joint, sciatic nerve, then the wrist dislocation is the median nerve, and finally the knee dislocation or the injury might result in the common peroneal nerve injury, right? So they are giving you the X-rays and then they are asking you what is the name of the nerve which are likely to be injured or what are the features of the nerve injury which could be associated with this injury to the bone, right? A question is puri table mein se, means although we cannot say it directly, but every time you go through the previous year questions asked, is table mein se ek question hamesha aapko milega, right? Then comes several of the spine segmental kind of the questions which could be or couldn't be kept in your examination, but there is increased frequency जिसमें कि आपको एक X-ray मिलता है for the purpose of its identification along with the clinical features. Now, one such condition which is very clearly obvious that one of the vertebra is displaced in relation to the above, and that condition is known as spondylolisthesis, right? So for that they will give you an X-ray of the vertebral column, jahan pe there is a posterior dislocation or subluxation of one of the vertebra or displacement of the vertebra over to the other, then this condition is known as spondylolisthesis. Now, spine se related aapne do X-ray pad liye. One was a single level spondylodiscitis which was happening in tuberculosis of the spine, and the other one is spondylolisthesis, और दोनों आप easily identify कर सकते हो. Then another condition is ankylosing spondylitis. So what you have to remember about this particular condition, you know, there are majority of them there are so many important hints in the question. The first hint always is pain which is relieved on exercises. All right, the patient might be experiencing the low backache which is relieved on exercises. If it is provided to you in the question, answer for that question is ankylosing spondylitis. The hint number 2 is the extra-articular clinical features. Extra-articular clinical features which are related to the acute anterior uveitis, जिसमें कि red eyes, right, glaucoma, cataract. Then there are several clinical features which are related to the cardiac insufficiency, right? The third degree heart block, aortic valvular insufficiency, the apical pulmonary fibrosis, difficulty in breathing, prostatitis, retroperitoneal fibrosis, the inflammation of the, that means inflammatory bowel disease. So all these are the features which will be kept in your examination in the form of the hint. And finally, you know about the x-rays like bamboo spine, the calcification of the intervertebral disc, the calcification of all the soft tissues around. So if these are the things which are provided to you in the question, coupled with an x-ray where the bone is seen in continuity, the bone is visualized in continuity, then this becomes an answer for your question, that is ankylosing spondylitis, right? So spine se related 3 x-rays we have learned. One was tuberculosis of the spine, the second one is spondylolisthesis, and the third one is ankylosing spondylitis, and all 3 of them are different, right? Okay. Now this is the kind of the one-liner which the examiner tends to give you back and again and again. They used to give these kind of the questions like tennis elbow, lateral epicondylitis; golfer elbow, medial epicondylitis; tailor ankle, lateral malleolar bursitis. So these are the one-liners. Weaver bottom, ischial bursitis. Now, last year also they have asked the question on this housemaid and the clergyman knee. The clergyman knee is infrapatellar bursitis. That means below the level of the patella. While housemaid knee is prepatellar bursitis. Right? So, these are the kind of the questions which the examiner tends to give you in the form of the one-liner. Tennis elbow, all of you know, lateral epicondylitis, and the golfer elbow is the medial epicondylitis. Right? Similarly, osteonecrosis or osteochondritis in the form of the one-liner, that could also be asked, like Kienbock disease is the avascular necrosis of the lunate bone, the lunate. Panner disease is that of the capitellum. Then Kohler disease is that of the navicular bone. Then Osgood-Schlatter disease is that of the tibial tuberosity. Then severe disease is that of the calcaneal apophysis. Calcaneal apophysis. Now, Freiberg disease is that of the head of metatarsals, particularly the second metatarsal in particular. Perthes disease is the avascular necrosis of the epiphyseal head of femur. That means epiphyseal head of the femur, obviously in case of children, while Chandler disease is avascular necrosis head of femur in case of adults. So these are again the one-liners in the form of osteonecrosis or osteochondritis. ये एक one-liner sort of the question होता है जो कि आपके segment 6th को involve करता है ना, in the orthopedic related question. And these one-liners could be framed either out of the bursitis kind of the table that we have talked about and the osteonecrosis kind of the table that we have talked about. Although there are other osteonecrosis conditions also, but they are not that common. Like Friedreich disease is also there, Adam disease also there, Albach disease is also there, but that is less likely to be kept in your examination. ये वो common conditions हैं जो कि पूछी जा सकती हैं exams में. Then finally, then the next segment is, the 7th segment is asking about the lower limb trauma. Or lower limb trauma में particularly they are likely to give you the dislocation related trauma, right? Dislocated related question. क्योंकि एक potential question है, इसके attitudes different है, उस attitudes को they can give you in the question or they can ask you in the answers, right? So dislocation of the shoulder. Now here what we are going to try to make the process easier for you to learn. देखिए, dislocation of the shoulder can be anterior or posterior. Similarly, dislocation of the hip could be anterior or posterior. जो भी question आता है वो आता है related to the attitude, that what would be the position of the limb when it is anteriorly dislocated. For example, if the shoulder is anteriorly dislocated, the patient would come with flexion, abduction and external rotation deformity. That means the limb would be kept in flexion, abduction and external rotation. While in case of posterior dislocation, it would be kept in adduction and internal rotation. Similarly, in case of dislocation of the hip joint, for anterior dislocation, it would be kept in abduction and external rotation deformity. While for posterior dislocation of the hip joint, it would be kept in flexion, adduction and internal rotation deformity. इसी के basis पे question आते हैं always. For dislocation of the hip or dislocation of the shoulder, they will ask you a question based on their attitudes, based on their abnormal position in which it is kept. Now, if you try to if you try to correlate it with this question, a person met with an accident while sitting in the front seat of the car, following which he was presented to the emergency with the right thigh inflection, adduction and internal rotation. So what else is needed? Flexion, adduction, internal rotation. Front seat of the car, that means dashboard injury as a mechanism is also provided to you in the question, right? So flexion, adduction, internal rotation along with the dashboard injury. X-rays are as follows, where it is very clearly seen that the head of the femur is out of the acetabulum. Then answer for that question is posterior dislocation of the hip joint. तो इस तरह से questions आपको मिलेंगे related to anterior or posterior dislocation of the hip joint. So that was segment 7th, all right, of the orthopedic question. नेक्स्ट सेगमेंट इज दैट ऑफ अ मेटाबॉलिक डिसऑर्डर. देखो मेटाबॉलिक डिसऑर्डर में सिंपल क्वेश्चंस होते हैं, एक तो रिकेट से रिलेटेड, ऑस्टियोमलेशिया से रिलेटेड और ऑस्टियोपोरोसिस से रिलेटेड. एक विटामिन डी मेटाबॉलिज्म का जो फिनोमेना है, तो पूरा फ्लो चार्ट है दैट यू शुड बी ऑलरेडी नोइंग अबाउट, कि उसमें 7 डिहाइड्रोकोलेस्टेरॉल, देन 25 हाइड्रोक्सीकोलिकैल्सिफेरॉल, देन 125 डाइहाइड्रोक्सीकोलिकैल्सिफेरॉल. सो ये पूरी चेन आपको मालूम होनी चाहिए. एंड व्हाट आर द कैटालिटिक, व्हाट आर द एंजाइम्स, व्हाट आर द फिनोमेना, what are the organs, what are the responsible factor which are promoting the alpha-1 hydroxylase activity. So each and every of this thing that you should be knowing about. Vitamin D metabolic pathway बहुत simple है. Very frequently they used to ask this question, right? कभी कभी from the biochemistry perspective, physiology perspective or from the orthopedic perspective. So sunlight causes conversion reaction for the formation of which of the following? Already you know about that. 7 dehydrocholesterol is getting converted into cholecalciferol. So cholecalciferol is created by UVB radiations. Now rickets. अब rickets से related there are going to be three important points. ये आप कैसे identify करोगे कि question rickets से है? Point number 1, अगर सीरम कैल्शियम is normal, alkaline phosphatase is elevated, alright, ये values आपको मिली हुई हैं क्वेश्चन के अंदर, and X-ray of the wrist is already provided to you, then answer for that question is ricket. That means they are asking about rickets. अब सीरम कैल्शियम की वैल्यू नॉर्मल क्यों दी जाती है? क्योंकि जो न्यूट्रिशनल डेफिशिएंसी रिकेट होता है, दैट इज विटामिन डी डेफिशिएंसी रिकेट्स, इज responsible for decreasing the calcium metabolism in the human body, as a result of which the calcium in the blood is also depleted and that is compensated by parathormone. तो parathormone क्या करता है कि all the calcium would be mobilized from its reservoirs into the circulation. So that is the key point related to rickets. और रिकेट्स के एक्सरेज में आप क्या क्या आइडेंटिफाई करोगे? दैट द मेटाफाइसिस वुड बी कप्ड, द मेटाफाइसिस वुड बी हैविंग इरेगुलर बॉर्डर्स एंड द मेटाफाइसिस वुड बी स्प्लेड आल्सो. देयर विल बी वाइडनिंग ऑफ द मेटाफाइसिस. सो मेटाफाइजियल कपिंग, मेटाफाइजियल फ्रेइंग, मेटाफाइजियल स्प्लेइंग. सो कहने का मतलब ये है कि रिकेट से रिलेटेड क्वेश्चंस आपको अलग अलग डिफॉर्मिटी प्रेजेंटेशंस में मिल सकते हैं. मोस्ट कॉमनली जो क्वेश्चन मिलेगा वो आपको डिफिकल्टी इन वॉकिंग में मिलेगा, या डिफॉर्मिटी नोटेड इन द लोअर लिम्ब बाय द पेरेंट्स में मिलेगा. लेकिन आपको आइडेंटिफाई करना होगा कैल्शियम लेवल पे और एल्कलाइन फॉस्फेटेज की लेवल पे. और अगर एक्सरेज ऑफ द रिस्ट आर आल्सो प्रोवाइडेड टू यू इन द क्वेश्चन, देन योर आंसर इज सर्टेन, राइट? रिकेट्स. दूसरा होता है स्कर्वी. अब स्कर्वी से रिलेटेड जो क्वेश्चन होते हैं उसमें देयर आर गोइंग टू बी द एक्सरे फाइंडिंग, द की एक्सरे फाइंडिंग्स, एंड द 2 की एक्सरे फाइंडिंग्स दैट यू हैव टू आइडेंटिफाई in scurvy patients, although there are multiple other x-ray findings are, one is ring sign of Wimberger's, the ring sign of Wimberger's, where the outer margin of the epiphysis is denser compared to its core, that is ring sign of Wimberger. The second one is increased in the density. देखो, if you look at this, the density of the end of the metaphysis is increased, and this is known as white line of Frankel. The white line of Frankel is actually increase in the density of the zone of the provisional calcification in the growth plate, right? And the other thing that you can also see is the increase in the projections of the metaphysis, the sharp projection of the metaphyseal end, and these are known as Pelkan spur. तो ये आता है scurvy से related question. Although scurvy से related question is not that very frequently asked, लेकिन हाँ, white line of Frankel is something that they used to ask very frequently, जिसका हम आंसर देते हैं rickets, but rickets is not the answer for this question. Scurvy always is the answer for this white line of Frankel related question. Osteoporosis से related आपको identification में एक X-ray मिलेगा. उस X-ray में the importance would be that the multiple of the vertebrae would be collapsed, right? Multiple of the vertebrae would be collapsed, अगर ये एक्सरे आपको मिलता है देन यू आर लुकिंग एट द एक्सरे ऑफ द ऑस्टियोपोरोसिस. ऑस्टियोपोरोसिस से रिलेटेड क्वेश्चंस आर बेस्ड ऑन टी स्कोर and based on the management, and both these two things you already know that if the T score is less than minus 2.5 it is osteoporosis, and the management primarily is based on bisphosphonates, right? Osteoporosis से related questions भी पूछे जाते हैं and we are. तो हमने जैसे वर्टिब्रल कॉलम के एक्सरेज हम देख रहे हैं, तो हमने फोर्थ एक्सरे, दिस इज द फोर्थ एक्सरे. फर्स्ट वन वाज ट्यूबरकुलोसिस, सेकंड वन वाज दैट ऑफ द स्पॉन्डाइलोलिस्थेसिस, द थर्ड वन वाज दैट ऑफ द एनकाइलोजिंग स्पॉन्डिलाइटिस, एंड द फोर्थ वन इज दैट ऑफ द osteoporosis. Osteoporosis में क्या होता है कि multiple of the vertebrae when they are found to be collapsed, all right, without any significant trauma, with the decrease in the density of the bone, then answer for that question is porotic bones, like osteoporosis, right? Now this is something which you already know about. Identification based question जो होते हैं, segment 11th में we are talking like cubitus varus, cubitus valgus. So if this is normal, where the long axis of the bone, long axis of the arm and long axis of the forearm is creating a carrying angle of around 7 to 13 degrees. But if the things are reversed, then this is varus deformity, where the apex is pointing away from the midline. While if the things are reversed, where the apex is pointing more towards the midline of the body, then this is cubitus valgus. So it is valgus and the varus deformity for the purpose of its identification. इसी तरीके से genu varum, genu valgum होते हैं. Like if the knee, this is the normal knee joint. Sorry, but if the knee is pointing away from each other, this is varus, while if the knee is pointing towards each other, then this is valgus. This is valgus deformity. So mediolateral angulations with the joint in extension could be termed as varus or valgus deformity based upon the apical angulations. ये बहुत simple question. Like in this case, as you can see, this is normal, but here the apex is pointing more towards the medial compared to the normal one, so it is cubitus valgus deformity, है ना? और ये cubitus valgus किसके साथ associate होता है, cubitus varus किसके साथ associate होता है? These are the several of the things that you should already be knowing about at this level, at this point. Now the most common joint which is involved in septic arthritis we have already talked about. It is knee joint. Now which part of the scaphoid, देखो scaphoid से related जब भी हम बात करते हैं तो एक क्वेश्चन जो हमेशा हमने बताया है कि स्कैफॉइड से रिलेटेड आपके दो ही इंपॉर्टेंट टॉपिक्स रह जाएंगे क्वेश्चन के अंदर. द फर्स्ट वन इज दैट इफ देयर इज अ टेंडरनेस इन एनाटॉमिकल स्नफ बॉक्स, राइट, दिस एनाटॉमिकल स्नफ बॉक्स टेंडरनेस अगर आपको क्वेश्चन में प्रोवाइडेड है देन पॉसिबली दे आर आस्किंग अबाउट द स्कैफॉइड फ्रैक्चर. दूसरा कंडीशन होती है decquervantinosynovitis, but that is not very commonly kept in your examination. And the second thing is related to its complications. जो complications होते हैं related to scaphoid fracture, these are two complications. One is avascular necrosis of the scaphoid, and this avascular necrosis is actually more common in the proximal pole compared to the distal pole. एक तो ये difference है दोनों के बीच में. And the second one, the second common complication is the non-union, right? So these are the things which are very frequently kept, है ना? और उसके पीछे की reasonings we already know, like if this is the scaphoid bone, this is the proximal part, this is the distal part. अगर यहाँ पर fracture हो जाता है, then the proximal part, because it is not having, the distal part is having a vascularity, independent vascularity, but the proximal part is devoid of the vascularity. तो जिसकी वजह से there will be a cut in the vascular supply. So the avascular necrosis is more commonly seen in the proximal pole compared to the distal pole, है ना? और दूसरा non-union. यही दो क्वेश्चन होते हैं related to the scaphoid. तीसरा क्वेश्चन होता है related to the cast management, और वो होता है identification के बेसिस पे, that is glass holding cast, and we have already talked about how to identify that glass holding cast, right? Next point is related to the gout. You know, an important distinguishing feature in between gout and pseudogout is that if we write this is gout and pseudogout. Now gout is a purine metabolic disorder, while pseudogout is not a pyrimidine metabolic disorder. Pseudogout is a degenerative arthritis. Like, now the name of the crystal in case of gout is monosodium urate. This already you know that monosodium urate monohydrate crystal, right? But the crystal in case of pseudogout is calcium pyrophosphate dihydrate. So these are the two differences, basic differences. Now as far as crystals are concerned, The crystal of the gout is needle shaped while the crystal of the gout is rhomboid, and when it is subjected to plane polarized microscopy, it shows negative birefringence, while when it is subjected to plane polarized microscopy, the crystal of the pseudogout reveals positive birefringence. And there is a peculiar involvement of a small joint in case of gout, particularly the first metatarsophalangeal joint, while the large joints are involved in case of pseudogout, particularly the knee joint. So these are the basic differences in between the two. अब अगर हम इस क्वेश्चन को देखें कि पेन इन द राइट नी, मैसिव स्वेलिंग, पटेला टैप पॉजिटिव, आर्थ्रोसेंटेसिस डन, साइनोवियल एस्पिरेट रिवील्ड नीडल शेप्ड क्रिस्टल्स एंड नेगेटिव बायरेफ्रिंजेंस. So knee joint involved होता है pseudogout में, but it does not mean that the gout cannot affect a large joint, है ना. एक tendency है small joint के involvement की, but it can also affect the large joint. And moreover, the needle shaped crystals which are negatively birefringent on plane polarized microscopy goes towards the gout. तो ये gout related questions particularly common होते हैं as far as their medications are concerned, कि acute gout में कौन सी यूज करनी है, chronic gout में कौन सी यूज करनी है. They might give you a condition and then they will ask you what is the management to begin with. But ये क्वेश्चन होता है based on the crystals, based on the joint involvement, based on its tendency, based on its propensity, कि which of the following is the likely answer for your question in this particular one, in this situation, right? So gout is the answer for this particular question. कोलीज फ्रैक्चर पे क्वेश्चन आना ही आना है. दे आर आस्किंग अ क्वेश्चन ऑन कोलीज फ्रैक्चर. सिंपल सा फंडा है कि इफ ओल्ड फीमेल इंजरी टू रिस्ट, इफ इट इज प्रोवाइडेड टू यू, देन आंसर फॉर दैट क्वेश्चन इज कोलीज फ्रैक्चर. विदाउट थिंकिंग ट्वाइस यू हैव टू मार्क द आंसर एज कोलीज फ्रैक्चर. अगर cherry on top, if they give you any other information like dinner fork deformity, then your diagnosis is for the certain dinner fork deformity is provided to you, along with the added complication of malunion, along with the added complication of pain and stiffness, right? If these are the things in addition provided, then your diagnosis is more certain. Otherwise, old age, injury to wrist, answer is Colles fracture, simple, right? Identify the deformity. This is something which we have already talked about जब हम varus valgus के identification पढ़ रहे थे, that these are the kind of the deformities which are very commonly seen in case of, particularly in case of rickets. लेकिन हाँ, how to identify it? If the apex is pointing away, it is varus. If the apex is pointing towards, more towards the body compared to the normal, it is valgus. So here it is gnu, that means representing the knee joint, and here we are seeing a gnu varus deformity, right? इस तरह के क्वेश्चन रिलेटेड टू द कॉम्प्लिकेशंस भी बहुत कॉमनली पूछे जाते हैं. लाइक सुप्राकंडाइलर फ्रैक्चर से रिलेटेड तो क्वेश्चन आपका कॉम्प्लिकेशन पे ही आएगा, राइट? सुप्राकंडाइलर फ्रैक्चर्स ऑफ द ह्यूमरस पे क्वेश्चन जब आता है, इट इज बेसिकली डिवाइडिंग इट इनटू 3 टाइप्स ऑफ द कॉम्प्लिकेशंस. एक होता है इमीडिएट कॉम्प्लिकेशन, एक होता है अर्ली कॉम्प्लिकेशन, एंड द अदर वन इज लेट कॉम्प्लिकेशन. तो जो इमीडिएट कॉम्प्लिकेशन होता है, दैट इज ईदर द आर्टीरियल और द नर्व इंजरी. अब उसमें जो आर्टरी है विच इज लाइंग राइट इन फ्रंट ऑफ द सुप्राकंडाइलर रीजन इज द ब्रेकियल आर्टरी. सो आर्टीरियल इंजरी इज द ब्रेकियल आर्टीरियल इंजरी, व्हाइल द नर्व इंजरी इज द एंटीरियर इंटरऑशियस नर्व इंजरी. अर्ली आर्थराइटिस में क्या होता है, मींस अर्ली कॉम्प्लिकेशंस आर द कंपार्टमेंट सिंड्रोम, एंड द लेट कॉम्प्लिकेशंस आर द malunion, जिसमें कि द टेंडेंसी ऑफ दीज फ्रैक्चर्स टू गो इनटू malunion आर हायर, एंड द सेकंड वन इज मायोसाइटिस ऑसिफिकेंस. सो जब भी कभी सुप्राकंडाइलर फ्रैक्चर से रिलेटेड क्वेश्चन आएगा तो क्वेश्चन आता है कॉम्प्लिकेशंस के ऊपर. नाउ 6-year-old इंजरी टू एल्बो, रेडियल आर्टरी फीबल, हैंड मूवमेंट प्रेजेंट, एक्सरेज आर द एज सून एज गिवन, वेसल एट डेंजर. So here you have to identify that this fracture is above the level of the supracondylar region, condylar region of the elbow. It is supracondylar fracture of the humerus, likely to injure a brachial artery, all right, as an immediate complication. जब भी कभी आपको कोई क्वेश्चन मिलता है रिलेटेड टू द ट्यूमर इन द हैंड, ट्यूमर इन एनी बोन इन्वॉल्विंग द हैंड, देन आंसर फॉर दैट क्वेश्चन इज एनकॉन्ड्रोमा, है ना? ट्यूमर से रिलेटेड एक क्वेश्चन आना ही आना है. So it could be either GCT, chondroblastoma, osteochondroma, the osteosarcoma or the enchondroma. तो जब ट्यूमर ऑफ द हैंड होगा, which is highlighted obviously, then answer for that question is enchondroma. All right. So hopefully the session was helpful. हमने यहाँ पे जो डिस्कस करे हैं वो करे हैं अराउंड 11 to 12 सेगमेंट्स. इन्हीं सेगमेंट के फ्रेम में मेजॉरिटी ऑफ योर ऑर्थोपेडिक क्वेश्चंस वुड बी सॉल्व्ड. मेजॉरिटी ऑफ द क्वेश्चन नंबर 1 इज द नर्व इंजरी. नर्व इंजरी से एटलीस्ट 1 to 2 क्वेश्चंस आर एक्सपेक्टेड. सेकंड, ऑलवेज यू विल गेट अ क्वेश्चन आउट ऑफ अपर लिम्ब ट्रॉमा, जिसमें कि कोलिस फ्रैक्चर, सुप्राकंडाइलर फ्रैक्चर, द डिस्लोकेशंस ऑफ द शोल्डर. द थर्ड सेगमेंट आउट ऑफ विच द क्वेश्चन इज लाइकली टू कम, आएगा ही आएगा, एंड दैट इज the tumor, one of the questions from the tumor. The fourth segment is the identifying kind of the question, जिसमें कि brace दे सकते हैं, they can give you the cast, all right, just on the basis of the picture identification. So these are the critical segments. उसके अलावा there are individual topics like infections, like lower limb trauma, like the metabolic disorders, right? So hopefully the session proved to be helpful, and all the best for your examination. Don't worry too much. This is means what we are expecting, and hopefully it happens the way that we are expecting, that this time the patient is going to be filled up with PYQs. All right. All the best for your exams. Thank you.